Thank you very much. It's a real honor and pleasure to be here with Mike Scott and all the organizers and patients and prostate cancer advocacy folks on the line. These are my disclosures over the last 3 years. I guess suffice it to say I've been, involved in most of the, many of the companies that are dealing with prostate cancer and do research in the area. So these are my disclosures. I want to recognize Mike Scott, and I was trying to figure it out. I think I've known Mike since about 1991, and Mike was associated with my boss at Walter Reed, Colonel Dave McLeod, Dr. McLeod, who I think Mike met first, and then I got introduced, and we were doing some really early work way back in the late 80s, early 90s on oncogenes and tumor suppressor genes in prostate cancer. And gosh, compared to today, it was rudimentary, just really the early basic stuff. But Mike was really good to me. He was running prostate cancer educational symposia primarily for physicians back then. And I was a young guy, and I really always have appreciated the fact that he gave me a shot to give this talk on molecular biology of prostate cancer, and we've been friends ever since. So I just want to recognize his contributions to the field, over the last, again, he said 35 or more years. This is going to be kind of what I would call a prostate cancer tumor board, similar to what we would do, among urologists, radiation oncologists, and medical oncologists at Duke or at any other major medical center when we present gentlemen with prostate cancer and are trying to figure out the best way to manage their case in a multidisciplinary fashion. And it's going to be case-based. As Mike said, I'm going to try to limit my formal comments to, 25 or so minutes. And we're really focusing on recurrence after initial primary therapy. So that's going to be the focus. Once we get to the questions, we can talk about anything you guys want, but for this didactic or the formal portion, we're going to talk about recurrence after initial primary therapy, and that could be after radical prostatectomy, after radiation therapy, after cryotherapy, or after high-intensity focused ultrasound, although we're not going to go into detail on cryo or HIFU. We can talk about that, the question and answer. So this is the first case that we're going to present is a 63-year-old male who is 3 months status post a radical prostatectomy. He, at this point, is continent, which is great. He's not leaking urine. He's not wearing pads. But he has no erections yet, which is typical at 3 months, certainly. His stage is PT3A. In plain English, he has some microscopic cancer on the edge of the prostate gland that was removed. The Gleason score is 4 + 3 = 7, which is middle grade. He has unilateral seminal vesicle invasion. The seminal vesicles are attached to the prostate, and at least a portion of them are removed with a prostatectomy. And he has some microscopic cancer cells in one of those two organs. He has a 0.5 centimeter positive surgical margin. PSM stands for positive surgical margin, meaning over that distance of a half a centimeter, he has some Gleason 7 prostate cancer that the pathologist sees on the edge of the removed specimen. But the good news is his PSA is considered, for practical terms, undetectable at less than 0.1. And so the question, if we're presenting this case at a tumor board, anything to do at this point related to the prostate cancer. So we don't have a system set up for a polling here, but the options would be either to observe this gentleman. We could give him adjuvant radiation to the prostate area. In other words, we could just automatically sterilize that area, if you will, with some radiation treatment, and that certainly used to be commonly done. We could give him hormonal therapy. I think everyone on the line knows about hormonal therapy for prostate cancer, and perhaps you could do hormonal therapy, or the hot topic in 2021 is ordering a PET scan. And there's a growing number of new types of PET scans that can be used in prostate cancer. So those would be our options. Now, based on the latest guidelines, the correct answer is number one, to observe this gentleman. The reason is that his PSA currently is considered very, very low, what we would consider as, for practical terms, undetectable. And so we believe he could be cancer-free. Hormonal therapy would be wrong because the PSA is undetectable after surgery, and there's no clear indication that he has any cancer left in his body, even though he had some cells on the edge. The PET scans, there's currently a commercially available scan called Axeman, and then there's a number of emerging companies developing something called a PSMA PET scan. And unfortunately, even though these tests are better than some of the imaging we used to have, like bone scan and CAT scan, they're not accurate when the PSA is this low. So they only become accurate when the PSA is more than about 0.5, or in some studies, actually above 1. And this gentleman has a PSA less than 0.1. So the teaching point for case one is that right now we would observe. Now, a number of other questions that we can address when we get to the question and answer session is there any role for something called Decipher testing? Decipher is a molecular test that's done on the prostate tissue that was removed at the time of surgery. It's done on the radical prostatectomy pathology tissue, and it's commercially available, and it measures using a gene chip technology. It measures a whole bunch of genes, expression of these genes, and they use a certain subset for their commercial test they call Decipher, and that has gained in popularity at this point, although it remains controversial. Another question, how often do you check the PSA on a gentleman like this? And typically it's about every 3 months. What is the threshold PSA to define a recurrence? And it would typically be above 0.2, although again, in practical terms, many times there's a certain gray zone between about 0.2 and 0.4 where we're not sure. So as far as applying additional treatment like radiation, most experts wait till the PSA is about 0.4 or 0.5. When to order the new PET scan? Well, not now when the PSA is undetectable, but if the PSA certainly went above 0.5, then it would be certainly reasonable. And some doctors are ordering the PET scan when the PSA is above 0.2, although they need to explain to their patients that there's a lot more uncertainty onto the accuracy of the PET scan when the PSA is that low. When to use hormonal therapy? Well, we could spend the rest of the evening just talking about that, but in general, most of the time you don't really start hormone therapy till the PSA is, well, if you're not using any other treatment, you typically would wait till the PSA is above 2.0, or if you're using short-term of hormone therapy with radiation, it would be only after you make the decision to give radiation, and the PSA would have to be typically above 0.4. What type of hormonal therapy? Well, up until recently, it was only injections, drugs like Lupron or Eligard or Trelstar. But now there's a new pill that is called Orgovix, which is just out since December and just basically in the supply chain in the last couple of months. We can talk about that more at the question and answer session. And by the way, as I'm going through this, feel free to jot down questions or even put them in the chat box so you don't forget. Now we can use that as a springboard for discussion in a bit. And then what about sexual recovery after surgery? Well, this gentleman is 3 months out, and usually even if he had a nerve sparing surgery, most men don't regain erections till more like 9 to 15 months after the surgery. So at 3 months, no one would really expect him to have erections at this point. Let's go to case.
Before you move to the next one, I had one quick question, Dr. Moul.
Sure.
In this particular case, the patient was, I think, Gleason 4+3.
Let's go back to, yes, 4+3.
Would it have made any difference in your mind if this patient was 3+4, i.e. favorable intermediate risk as opposed to unfavorable?
Not really at this point. Again, interestingly, the current guideline would say, regardless of the Gleason score, whether it's a 4-3, 3-4, 4-4, whether it's a Gleason 6, 7, 8, 9, or 10, the current guidelines are calling for waiting and seeing what the PSA does before we pull the trigger for post-op radiation.
Thank you.
So this would be fairly straightforward because we don't want to overtreat someone. We don't want to make the treatment worse than the disease itself. And Mike, your point is well taken. If the Gleason score is a 3 + 4 = 7, it means that there's even less likelihood that this gentleman would recur. So let's move on to case 2, which is a 64-year-old African-American male. His initial PSA by his primary care physician was 12. His digital rectal exam, you see there DRE, digital rectal exam, was what we call T2B. In plain English, he had a feelable or palpable lump on his prostate, which was presumably the cancer. His prostate biopsy, again, TRUS stands for transrectal ultrasound prostate biopsy, showed 7 out of 12 cores with Gleason 7, but he also had low volume Gleason 8. So from a clinical practical standpoint, usually the highest Gleason score trumps everything else. So we base our workup as to whether this gentleman needs further testing, for example, based on the worst or the highest Gleason score. So he had Gleason 8, and because of the Gleason 8 and because his PSA was greater than 10, by guidelines, his doctors appropriately ordered a bone scan and a CAT scan, which showed no signs of metastatic prostate cancer, which was obviously good news. He went on then to receive a full course of external beam radiation therapy as his primary treatment, and he received 6 months of hormone medications about 3 years ago. His nadir PSA, which is like the lowest level or the trough PSA that he got to, if you will, after radiation, was 0.1. So he got to a healthy, very low PSA trough or nadir of 0.1, but now his PSA has risen to 4.2. So this is now 3 years later, and this gentleman, unfortunately, has experienced what we call a PSA, or what other doctors call a biochemical recurrence. Biochemical meaning that it's because the PSA is a chemical or a biochemical, they call it a biochemical recurrence. So here are the options that we have for this gentleman. So one option would be to treat this gentleman with Leuprolide, which is either Lupron or Eligard. You could treat him with Degarelix, which is the pure GnRH antagonist called Firmagon. You could also treat him with the brand new oral treatment called Relagolix. it took me a while to learn how to say that, but it's relugolix. And that is trade name called Orgovyx, which is a hormone pill which takes the place of either leuprolide or degarelix. So that now is an option if the patient wants to try the pill or does not desire the injections. You could order a PET scan, and in this particular case, a PET scan would be reasonable to do because the PSA is already over 4, and a PET scan might find microscopic prostate cancer in an area such as lymph node tissue or bone tissue. And the other thing you could do, you could do a biopsy of the prostate to look for a recurrence. Remember, this gentleman had radiation treatment and not a radical prostatectomy, so he still has his prostate gland in place. And so you would consider a biopsy, especially if the gentleman was interested in some form of additional local therapy, and that's called salvage, like a salvage prostatectomy or salvage cryotherapy or salvage high-intensity focused ultrasound. When they put the term salvage in front of it, which might sound kind of weird or kind of unusual, the salvage means they're trying to salvage a cure with a second local treatment. He already had the radiation, and now you're trying to salvage his cure with another treatment to the prostate. But order a bone scan and a CT scan, which would be the standard workup, and that's the testing that's been done and continues to be done for years before these PET scans came on the scene. I suppose you could reassure the patient and follow him. And you might say, why in the world would you do that? You know he has a recurrence of prostate cancer. Well, he may be in poor health. He may have other health conditions, and his life expectancy may be limited. So, and prostate cancer in many cases does grow very slowly. So it's possible this gentleman could have a rising PSA that would just smolder along, and he could live a normal life for maybe even 10 years or more. So sometimes it is very reasonable just to follow these men and not be aggressive with additional treatment. So here's some questions. Is this even a recurrence? Well, the academic answer is yes. And the reason is that by convention and by definition, a PSA that rises 2 full points from the nadir or the trough level is considered a recurrence. So remember, this gentleman nadired his PSA at 0.1, and now his PSA is over 4. So he's clearly demonstrated a recurrence. It may not be a serious recurrence. He may not have visible recurrence on a CAT scan, bone scan, or PET scan, but it is a biochemical recurrence at least, because the PSA is higher than it should be. A question that it's not clear the answer. How do you decide between leuprolide versus degarelix versus relugolix? Well, quite frankly, right now, some of that is dependent on insurance coverage. Leuprolide and degarelix have been around for a long time. They're given typically in the doctor's office by shots or injections, and Medicare and the other insurance cover, pay for that pretty regularly because it's been around so long. The relugolix is a brand new option. It's a pill form, and it's so new that it's not yet covered or completely covered by many health plans. So it's exciting, it's new, but it may not be completely covered. How do you decide between doing a PET scan versus a traditional CAT scan and bone scan? Well, if you want the honest answer, much of that is determined by your insurance company. Many times, health plans will only cover the CAT scan and the bone scan because those are the traditional tests. And one of the challenges we face in the trenches is getting these PET scans covered because they're new and they're expensive, and not all insurance plans figure that they're necessary. So it sometimes is a challenge to do that. When do you biopsy the prostate to look for recurrent cancer in the prostate gland? Only when you are considering further local therapy. So if this gentleman is enjoying excellent health, and this gentleman, for example, has a negative CAT scan and a negative bone scan, or perhaps also a negative PET scan, then you are confident that he does not have metastatic or spread prostate cancer. Then it might be reasonable to do a local therapy, such as, for example, salvage prostatectomy or salvage cryotherapy. And in order to get health insurance to pay for those salvage procedures on the prostate, you need to document a local recurrence inside the prostate gland with a biopsy. And then finally, is it ever appropriate just to follow patients like this without treatment? And as I said earlier, yes. Sometimes these cancers grow very slowly. Sometimes the PSA rises very slowly. And sometimes in elderly patients, it's better to do active surveillance, even for some of these recurrences, and not harm an individual with aggressive therapy. Then this, a couple just final other questions about this case. Again, the prostate gland is still present in this gentleman, and you would, if you wanted to do a second local treatment, you would need to confirm the local recurrence with a positive prostate biopsy for recurrent cancer. Healthy younger men with a PSA less than 10 might be candidates for a salvage radical prostatectomy, but a salvage radical prostatectomy is associated with a pretty high risk of complications and side effects, such as urinary incontinence and impotence, and even the risk of injury to the rectum, which in maybe 1% of patients could result in at least a temporary colostomy. So we take these salvage radical prostatectomies very seriously, and they're not as commonly done, especially in older gentlemen where we're concerned about side effects. He could be a candidate for salvage cryotherapy, even though the prostate gland has been radiated. And if he has just a local recurrence inside his prostate, that prostate cancer may be treated with freezing, which is the cryotherapy technique. He may also be a candidate for salvage brachytherapy or seed radiation, although that's a very specialized treatment only done at very, very experienced centers. And when you're doing brachytherapy as a salvage procedure, it really requires a top class radiation oncologist to do that procedure safely without side effects. Salvage high intensity focused ultrasound, I believe, is still considered experimental and would not be covered by health insurance, to my knowledge, in the United States. And certainly, if this gentleman had any metastasis, he would probably not be a candidate for salvage local therapy because he's already demonstrating metastatic disease, and it probably wouldn't allow him to live any longer by doing a secondary treatment on his prostate gland. I think, Mike, why don't we, do you want to just stop here? Those were to see if there's questions, and then maybe we can do this case only if we have time. This was
Why don't we do that? One of the things that you did not mention at all, Dr. Moul, is the issue of genetic testing and the degree to which some of these relatively high-risk patients might have odd genetics that would make them more eligible for newer forms of treatment over time. Would you consider genetic testing in a patient that was clearly progressing if he hadn't already had it as a high-risk patient?
That's a great question. And it's somewhat controversial because we know that molecular testing to look for, mutations is definitely the hot topic with metastatic prostate cancer, to certainly sometimes do biopsies of areas of metastasis, or even do a liquid biopsy of the blood to look for, molecular changes. And that's no question that that's being done in metastatic prostate cancer and castrate-resistant prostate cancer. The literature for, again, in this really focused topic on an early recurrence after radiation or surgery, to be totally honest with you, we're not generally doing molecular testing in this specific setting. Now, on the other hand, if the gentleman, let's say he had, let's say he had a strong family history and was never tested before, you could do constitutional DNA testing. In other words, do a cheek swab or do a blood sample to see if he might have inherited a, say, a mutation in BRCA, for example. But to my knowledge, even if this guy had a BRCA mutation, it really wouldn't, to my knowledge, change these things that I just talked about for this first recurrence.
So in the first case you presented, the patient had a PSA of less than 0.1 after treatment. Most patients are being monitored with ultrasensitive PSA tests at this point in time, correct?
Not necessarily. Not in the, we hear about it, but not necessarily in the real world. Many centers that patients that I see for second opinion, the lowest level of PSA is less than 0.1. And even if he had an ultrasensitive PSA, we have to be careful because of the confounding issue of residual benign prostate tissue remaining in the gentleman's body. And that's a really important point for all the folks on the line tonight, that today's radical prostatectomy in the era of robotics and in the era of even more modern traditional open surgery, we're not as aggressive. We're not doing as radical a radical prostatectomy as we used to. So we're leaving the neck, your entire urethra, and that can, in doing that, it lessens the side effects, but you have a higher chance then of leaving some non-cancerous prostate slivers, if you will, in the guy's body, and that will produce PSA. So
that was actually where I was going.
Yes.
My question is, do we have any idea what percentage of patients who might have a rising but very low PSA level over time after first-line surgery actually are only expressing residual prostate tissue as opposed to residual prostate cancer?
It's a great question. Years ago, Chris Ameling looked at that at Mayo Clinic, and in those days they found it was almost 1/3 of patients could have a PSA up to 0.4, and that not be due to cancer, but just due to benign tissue. I have not published it in my series, but we've looked at that in my series at Duke, and it's about 30% of my patients have a PSA that's not perfect. And, and some of those are as high as 0.4, just like the old Mayo Clinic series. And so the key teaching point, so this is case 3. This is a second recurrence. This is a real patient of mine, 73-year-old retired grocery store CEO. And 5 years ago, he had moderate volume, Gleason 4+3=7. He had a PSA of 13. He presented to our Duke multidisciplinary clinic, where we run a clinic every Friday at Duke where patients who are undecided about treatment, they can come in and they can see a urologist and a medical oncologist and a radiation oncologist all in the same session. So all three of us see the patient, and then we talk about the case, and then we talk to the patient, try to come to an agreed treatment. And this gentleman went through multi-D, and he elected surgery and had a radical retropubic prostatectomy. Unfortunately, he had fairly aggressive disease. He had pathologic PT3B, and in plain English, that means he had cancer in both of his seminal vesicles. And unfortunately, the Gleason score was a 4 + 5 = 9. So he had high grade disease. He was upgraded a couple, 2 Gleason groups when he ultimately had the surgery. So at that time, this was 5 years ago, he actually did receive adjuvant radiation. So in other words, at that time, he went ahead and just got radiation, even though his PSA was still undetectable. And he also received 6 months of hormone treatment along with the radiation. So he got 2 months of hormone treatment, then they did the radiation. He continued hormone treatment, then he got 2 more months of hormone treatment after the radiation ended. And then we stopped treatment. And then about 3 years ago, his PSA began to rise. And when his PSA got back up to 5, he restarted hormone therapy. So that would have been his second recurrence when his PSA got to 5 and he restarted hormone therapy, or ADT. His PSA declined to 0.5 point about 7 months after restarting hormone therapy, but now his PSA is back up to 6 while he's on continuous hormone therapy. So this is actually, I guess, his third go around with prostate cancer, because his PSA is now back up after continuous hormonal therapy. He underwent a negative bone scan and a negative CAT scan. So this gentleman fits the criteria of what we call M0 castrate-resistant prostate cancer, or some people call it non-metastatic castrate-resistant prostate cancer. So this is an audience poll where we are give the doctors 3 choices here, or 5 choices, but the A, B, and C are all 3 different oral medications that are FDA approved, that one could add in to the regular ADT for this stage of disease. One of those is a drug called enzalutamide. That is called Xtandi by its commercial name. The other one is apalutamide. That's called Erleada by its trade name. And the third is darolutamide, which is called Nubeqa. And these are both, and just to be open and honest, enzalutamide is a Pfizer drug, apalutamide is a Johnson & Johnson drug, and darolutamide is a Bayer drug. Very similar to what we're going through with the COVID vaccine, which is best. And so you have these 3 companies, 3 major companies, who all have these new oral agents, which are all in their own right very effective, and but they're so similar, and so similar in their effectiveness is it's difficult. There's really hard to say which is better, and so patients could be on any one of those. Or the fourth option is just not do anything and monitor the patient until he has metastatic disease on his scans. Or I suppose you could order a PET scan. That's an answer we can give for anything now. Oh, let's order a PET scan. And so the questions for this case, is there any current role for obtaining a PET scan for quote unquote extra staging? And I mean, in my opinion, probably not, because you already have these 3 very effective oral medications that have been shown to provide a ton of benefit to these patients. So I don't really see a role for PET scanning in this particular case. Although some experts would do a PET scan, and if they found some spots, metastasis, like small little spots on the bone or in the lymph nodes, then some centers are offering what they call SBRT, which is basically, doing spot radiation to those sites of micrometastasis, which is gaining in popularity, but currently there's really no evidence that activity or that radiation is going to allow men to live longer. So it's somewhat controversial. And then how do you decide between enzalutamide versus apalutamide versus darolutamide for a typical patient with M0? And the honest answer is it's difficult because all three of them are very effective. All three of them have some side effects, but it's difficult. And you know, it's interesting. And so sometimes this relates to the doctor may have a relationship with one of the companies, or when you're so involved in prostate cancer, I mean, I have relationships with all three companies. So I'm kind of neutral. I try just to alternate these drugs because it's not crystal clear academically which one, if there's one that's better than the other. So that's just kind of an honest answer. So that was my the third case, and maybe there's some questions that were generated from this third case.